Hi there, my name is Hannah Himes, and I'm going to be presenting briefly to you all today on early prone positioning within the setting of COVID-19 and acute respiratory distress syndrome. So let me move this so y'all can see here. The rationale for me choosing this as my project is I myself was a COVID ICU nurse during 2020 when it started presenting itself here in the States. And I saw my own healthcare facility as well as others were inundated with these critically ill COVID-19 patients, and we were all desperate and searching for solutions. So the question quickly presented itself to me: why are we not implementing this prone positioning, which I saw implemented in the ICU late in disease development when we're already intubated on high vent settings, on a bunch of maxed on pressors, all these medicines, patients very critically ill. The question came to me of why don't we try implementing prone positioning later in disease progression? Earlier in disease progression as opposed to later, which is when I had seen it implemented. Saw great results from it in that setting, but I wondered what would the results be if we presented this as an option earlier in disease progression. Would we avoid intubation? Would we avoid becoming critically ill? What are the results of that? So that's the rationale behind this project. And that is pretty much explained on this slide. So I dove into the literature surrounding this subject, specifically with early implementation versus late in ARDS specifically. So many of my studies, actually, articles that I procured were COVID-19 specific, but many of them were prior to COVID, of course. And so there's a mixture of them in there. I've got 12 critically appraised articles, 18 total, that have supported my evidence for this project. And as you can see here, we're talking about prone positioning being associated with decreased intubation rates, decreased mortality rates, increased oxygenation, decreased respiratory rate, and again, emphasizing the early implementation of this intervention as opposed to late. And that we see it's overwhelmingly supported by this evidence that I have gathered. On the right side of the screen here, you see an example of a graphic that, and again, I'll get into the implementation of my project here, but this is an example from one of the articles that is referenced at the end of this presentation. That was this image was produced by Joseph et al., which was published in the American Journal of Nursing back in 2021. It's an excellent example of what might be handed out to patients in a project such as mine. Who are the stakeholders involved in this project? So I'm sure there's even more than what is listed here, but some great examples to start with are the chief nursing officer and other people involved with hospital administration at my hospital. Of course, patients and patient families at the center of it all. Nurses, respiratory therapists, patient care technicians, physicians, physical therapists. Those people are the ones who, of course, the physicians might begin the conversation and be who decides to implement early prone positioning along with the rest of the team. But most of those people I just listed will be the people at the bedside helping guide the implementation of this maneuver. Of course, nursing managers, nursing supervisors, and charge nurses are stakeholders as well. Planned implementation. So my project is going to take place in 3 phases. Phase 1, planning, phase 2, implementation, and phase 3, evaluation. The implementation portion itself will take place over the course of 12 weeks. And of course, because of the nature of this disease particularly, it will depend upon individual patients and their needs. So at the very beginning of that 12-week period, there may not be 10 patients, maybe not even one, that presents to us as eligible to be included and approached about prone positioning early in their disease process. But throughout the course of 12 weeks, we will determine eligibility and approach those patients and begin the evaluation process has seen fit with those on an individual basis. So implementation will take place by educating the patient first. Usually that will be by nursing staff, and then offer the option of proning, and that will be voluntary. That will be by the patient, and the healthcare staff can guide the patient to do it, guiding them into prone position and then monitoring for outcomes. So this is the timetable and flow chart of basically what I just described with a little bit more detail. So you see phase 1 is preparation or planning. So this, I put on there 8 weeks. And before I begin getting into these details, please let me highlight that this will be a benchmark project because COVID-19 is not actively in our community anymore. Thankful for that. I'm unable to implement this project. So this is hypothetical for the purpose of this benchmark project. So phase 1 preparation, we're going to say that takes 8 weeks. Maybe it's 4 to 8 weeks where we get to meet with the committee that will involve many of the stakeholders I just mentioned on a previous slide. Identify those stakeholders, develop materials that can include the educational handout, an example of which was shown on a previous slide, as well as a questionnaire that we can hand out to individuals that decline wanting to prone position themselves early in disease development, trying to dive into the reason why so that we can have more evidence about that. Of course, this preparation phase will also include training of personnel, nursing, physicians, respiratory, and others of those stakeholders that I mentioned. Nursing will focus on guiding the patient into prone position if they so consent, and also the education of why the patient should consider proning and things of this nature, focused on education. Physicians, we want to specifically educate as to what are the eligibility or inclusion criteria that we want them to consider in scanning and reviewing these patient charts and the patients on their unit that could be eligible for this project. Respiratory therapists, of course, we want to be educated on this as well and be present for the maneuver for safety purposes. Phase 2 implementation, we have this set at 12 weeks. And again, as described a moment ago, the occurrences are going to be determined on individual basis. Eligibility determination, patient education and decision implementation of that prone positioning, and monitoring of various data at various time points after that maneuver has taken place. Phase 3 is evaluation. I have this set at 4 weeks where we will evaluate compliance. Was everyone who was eligible approached about this? And if not, why? Were the patients compliant, as in, did they consent to be guided into prone positioning? And if not, why? And that will take place with qualitative data gathered through a questionnaire after they may decline wanting to be in prone position. Quantitative data will be lots of data points we'll explore momentarily after the patient is proned. And then we'll just watch those outcome points and data points over time. And we'll go into this momentarily. Weekly committee meetings, of course, as we are gathering that data and evaluating and gathering it into a report that could be disseminated. Data collection methods. Much of this I just went into a moment ago. Qualitative data, again, that questionnaire of those who deny prone positioning, qualitative data of those who were involved in implementing the project. So a questionnaire that goes out afterwards and to many of those stakeholders that were mentioned so that we can gather qualitative data about their experience in implementing this project. Lastly, that quantitative data collection for those who were guided into prone positioning. The data that will be collected includes SpO2, PaO2, FiO2 that was required before and after prone positioning, oxygen delivery device that was required before and after prone positioning, respiratory rate. All of these will be collected before and after, and then respiratory effort as well, which is more of a subjective finding, but can be very telling for our purposes here. So those time intervals will be all of those data points collected immediately preceding therapy, 10 minutes after therapy, 60 minutes after therapy, every hour during therapy, so while they're on their front side in prone position, and follow up on discharge or completion of the study window. I think I skipped saying every 4 hours during a hospital stay as well. So the cost and benefit discussion. So monetary costs of implementing this benchmark project are quite minimal, to be honest. Educational material development and printing, as well as the questionnaire development and printing, that'll just be some paper and ink, not too much there. Where the money will come in is the paying the staff for being present for training and also for being present for evaluation, whatever that may include. Again, these costs are fairly minimal whenever you consider the vastly positive impacts that this project potentially has. So the benefits are those positive outcomes that are expected: low cost and low risk, high reward, integration into existing workflow. By that I mean we already have these patients that we're taking care of, and it's not going to be a huge disruption to the workflow of these nurses and other healthcare workers, and it's not going to be too disruptive either to train them. It might involve us going up to the unit and training while people are already on their shift, or perhaps coming in a little bit extra, maybe an hour on an off day. Shouldn't take too long to train these people. Overall discussion and results. So as previously mentioned, unfortunately, data is limited due to the nature of this project. COVID-19 has largely passed, thankfully, and this is a benchmark project. So it is hypothetical, but we are preparing in the nature that we were about to implement this project. So high expectations for positive outcomes due to the convincing body of evidence as reviewed earlier. Recommendations are to proceed with the project once there is the buy-in from stakeholders. So of course we need to make sure that administration is on board with this, as well as those many other stakeholders that were mentioned. But once that takes place, we can go forward with that, the planning or preparation portion, then implementation, then evaluation as highlighted previously. And then if all goes well and we do see especially those positive outcomes, we would love to disseminate this information in a professionally prepared report to other facilities that could be interested in improving patient outcomes with similar presentation. Here are my references on 2 slides here. And I would love to hear any questions or discussion points that you all would like to share in response to this presentation. Thank you so much for taking the time to listen, and that's all for now.